My name's Robin Hargreaves. I'm the Senior Vice President of the BVA. I've been involved in the final session of this forum on 2 or 3 occasions. It's a great session because it's very, very vibrant and everybody is ready for interacting. Got warmed up during the day. Nobody wants the last hour to drag. So please, I encourage you to get involved. We're going to talk about ethical dilemmas. We've got Paul and Dan. I'm not going to introduce because it's all in the paperwork. 2 very eminent speakers. And I'm fascinated by this. I'm genuinely fascinated by it. I work in small animal practice in the northwest of England, in a part of the country where there are no charitable outlets. We have no PDSA, no RSPCA. We see absolutely everybody, and we have to manage that. And we will have people who cannot and absolutely cannot afford the initial consultation fee, but have nowhere else to go. People who are well insured, but have little cash of their own. And we have people who've got more money than sense. So I have to balance those conflicting sort of demands, and I'm very interested to hear how other people would do that in a similar circumstance. So without any more hesitation, I'll hand over the stage to our 2 speakers. Thank you.
Thank you very much, Robin. That's not the first slide. Let's go back. Okay, welcome. And as Robin's already said, we want to try and make this session as interactive as we can. We've got the opportunity for you to express your opinions through the voting system. But what we'll also do as we work through this is try and work out a little bit more about who's voting how and why and the reasons for that. So there's going to be sort of open discussion, hopefully, as we go along. And the remit that I was given was to talk about how far is too far in the treatment and surgery of animals. Now, my history and recent presentations along a similar line told me that actually we can spend a long, long time just discussing one case. We've got a couple of cases prepared, but we'll make a start and we'll see how far we get. So you should all have handsets, voting handsets. I think probably important for you, for me to point out right at the outset, there is no intrinsic value to these handsets. When you get them home, they are absolutely worthless. They're not even aesthetically pleasing. So when you're done, if you could make sure you hand the handsets back, that would be fantastic. And just so that we can get you warmed up and make sure that the handsets are working, we've got an opening question for you. So the question that I'd like you to... now, actually, I'm seeing here... So somebody's advanced this slide. So bear with me just a second, because I've got to reset the thing, because we had 3 votes. This might take a little while. This is where Paul has to come up and do his... no, it's not going to reset session. Paul has to come up and do his song and dance routine. So with this remit, okay, let's see what we can do. Clearly, let's see if we can get your votes to register. So, yeah, I believe there are plenty of handsets. So it's saying polling is closed, and I want the polling to be open, please. Repoll question. Okay, now we're cooking on gas. So, during which month was this photograph made? This is not a trick question. I've got 88 responses. I can see the number of respondents on here. Unfortunately, you can't see that, but we got up to 120. So clearly, with this remit, there are lots of different scenarios that we could consider, but we'll explain the one scenario. We've got 135 respondents. So does anyone feel that they haven't and want to respond? So that gives me an idea of how many to wait for. These will allow you to vote once, but you can change your mind, and it will always go with the last vote that you made. That gives you an idea of the quality of the audience. That wasn't a trick question. That was that was my attempt at interpreting Charlie Chaplin during Movember in an attempt to raise awareness for men's prostate cancer in particular. I had to spend the entire month of November that year saying to folks that it wasn't a Hitler. Okay, so I want to know a bit about you, and I apologise profusely if you don't fit into any of these categories, but I thought it would be interesting to find out whom the audience was, and later on we can break down some of the results that we'll get according to where you're from. And so some idea of what your current role would be fantastic. So we're up to 120. Okay. Oh, we've got a lot of others. That's well, that will make for interesting reading later on, I think. Nearly quarter small animal practitioners and a good number of students, which is fantastic, and a few animal welfare scientists. So that's fantastic. So what we can do later on is look at who, from those demographic numbers, is voting in which direction. All right. So the scenario that I was asked to consider was, as you see here. So Mrs. Eden has a 2-year-old entire Cavalier King Charles Spaniel bitch named Project, and I'll leave you to read the rest. So the examination findings, she's a little overweight, she's bright, mucous membranes are cyanotic. I think originally it said a little cyanotic. Cyanosis is a little bit like pregnancy. You can't be a little bit cyanotic. You're either cyanotic or you're not. High respiratory rate and a grade 5 out of 5 heart murmur. Okay, so everyone's had a chance to look at that. And clearly, this is not about making the diagnosis, so there's a little bit of pattern spotting that we're hoping you're going to indulge in here. So what's your initial thought? This dog is likely to be in heart failure, and you can either strongly agree, somewhat agree, you can be neutral, and so on. So let's see how we feel about this patient. Okay, so we've got 134 responses. And so overwhelming majority either strongly agree or agree, and adding up the somewhat agrees, we've got quite a nice consensus there. Everybody in this room is concerned about the fact that this dog is in heart failure. Let's just see if we can work out. So the lime green are the small animal practitioners, and they are in fairly good agreement with each other. Excellent job, large animal vets, very good. Cross-species awareness there. Of course, I'd be very disappointed if the students didn't feel that this was what was likely to happen. So we got a dog here, and the idea was that you would quickly spot the pattern that we've got an animal that's got probably in heart failure, if not impending heart failure. And just to add a little bit of flesh, I don't want to dwell on this too much, but there's some very good research that's been done, a lot of it done at the Royal Veterinary College, looking at disease severity scores. And this is a paper that, once the clinical severity score system is finalised and validated, I think most of us will find very useful. And that's just to say that there are things that you can touch, feel and listen to in your consulting room that will give you a really accurate view of the prognosis for a patient with this type of disease. And so the variables independently associated with outcome would be a history of cough, exercise intolerance, decreased appetite, breathlessness, syncope, and murmur grades louder than 3 out of 6, loss of respiratory sinus arrhythmia. And when we add some of these together, we can come up with a very, very accurate prognostic indicator for these animals. And of course, this dog has several of these already. So really the point of this slide is to say we're all right to put those different things together, the cyanosis, the very loud murmur, the exercise intolerance, and to come to the conclusion or conclude that this dog's in serious trouble. So we'll go back to the scenario, and I'm going to ask the question, if congestive heart failure is confirmed on the basis of additional physical examination, radiographs, possibly you'll do an ultrasound, there's a very high probability that without treatment this dog would die a cardiac death within a year, and that probability is very high without being more specific. And so I'd like to know whether you strongly agree, somewhat agree, or so on. It's nice to see Robin's written my name down on a piece of paper here, just in case he forgot. We were actually at vet school together, and I saw practice with Robin in Shropshire, I think, when I was a second-year student, third-year student. DAN. Okay, so everybody here is either strongly agreeing or agreeing. So this dog is in real trouble, and we know that we're going to diagnose the disease severity using slightly more sophisticated means, as we said, ultrasound, radiographs. We don't do exercise studies in dogs, but this dog is in a real state. So which of the following conversations would you initiate with these owners? Would you tell them that the dog's got the dog's quality of life is poor and they should consider euthanasia? That the dog's quality of life is poor, but with medication a good quality of life could be restored for many years? The dog's quality of life is poor, but with medication a good quality of life can be restored for some months? That drug therapy can palliate the dog's signs, but the owners need to prepare for the fact that the dog will likely die within a year? Or that the owners need to consider surgical repair of the defective heart valve if they want to give their dog the best chance of a long-term improvement?
Is it insured?
Sort of irrelevant, David. Sort of irrelevant. Of course, it's very important. We're not talking about money. We're talking about the welfare of the patient right now. So, not welfare of the owners. I think it's really important that we do ask the question when we're considering welfare. Whose welfare are we protecting? Is it the owner's welfare or the animal's welfare, or is it both? And where does our biggest responsibility lie? But that's hopefully something we'll explore a little bit further later on. So we've got a couple of people not quite come off the fence. Oh, there we go. 135, that'll do. Okay. So looks like dog's quality of life is poor, but with medication, good quality of life could be restored for some months. And palliation, but the dog's likely to be dead within a year, are getting the most votes. And I think that would be a very reasonable position to take, given what we know as a profession about the progression of this disease despite treatment.
Did we see how the large
What an excellent question. So let's just have a look, because I haven't seen these slides either. So I've just got to have a look at them and see. Yeah, it looks like the large animal practitioners are pretty much in line with the majority there. That's fantastic. what's that? The animal welfare scientists very strongly in favour of considering euthanasia. So that's an interesting. So the veterinary professionals are all thinking we can palliate this dog, we can palliate it for a while, or we could do something else that would make this dog's life better for some time. And the animal welfare scientists are looking at this thinking euthanasia now, really. So would anyone like to just comment on why that would be the choice at this point for them? Anyone that voted that euthanasia should be considered? Yeah.
Am I on stage? Yeah.
You're on stage. Yeah.
Right. Graham Nuggetson, Animal Welfare Foundation trustee. I voted for euthanasia, and my reason was my poor old father died of congestive heart failure, and he had a very rough few weeks before he died. And so I've anthropomorphized. That was my reasoning.
You know, this is perhaps that's very interesting to hear, and I'm very sorry to hear that. Sorry, do you want to chip in? I think it's very interesting that we do anthropomorphise a great deal, and perhaps never more so than when it comes to cancer treatment, probably rather than cardiac therapy. I'm not sure that that's a fair thing to do necessarily. Certainly, dogs aren't busy making plans about what they're going to do next year. They live from moment to moment. So a rough time in a dog, perhaps in the way the dog would perceive it, is not quite the same as the way that you or I would perceive it, or we would see in others. Robin?
Yeah, a variation on what Graham was saying. For the very same reason, I've had an experience rather like that. But my choice was D, which was because it's the nearest to what I would say. But at that point, if people hadn't taken A sort of proactively and asked me to do A, if I said D, I would say, but you must not allow this dog to die. And I would say that to them. You know, we'll palliate this dog, but we must not allow it to die for exactly the same reason. So we would decide that euthanasia is going to be appropriate at some point, but not necessarily at this point.
So I think in terms of managing the owner's understanding and expectation of the disease, and also doing what you can right at the outset to prepare them, and also to prepare them to understand that it's in their gift to prevent suffering, that's a really important conversation to have. Not too many folks all too keen on surgical repair, but I'm very pleased to see that there are some votes in there. And of course, the reason I'm here is that we're very early on in our experience at the Royal Veterinary College of offering surgical treatment for a variety of different cardiac defects, acquired and congenital valvular and cardiac malformations. And of course, the mother lode of cardiac care is going to be in finding a very good treatment for mitral valve disease, surgical treatment for mitral valve disease. If we could come up with a good treatment, we've got a 2-year-old dog here. If we can get that right, we stand to gain a huge amount. Yeah. Very, very good comment, and absolutely. We look at the breeds that are affected, and they have a number of traits that we have bred, and if you look at Cavaliers in particular, it's not quite. I think I've been on record several times as saying, you know, brachycephalic dogs are an easy thing to fix. You just stop breeding short-nosed dogs with short-nosed dogs. You breed them with long-nosed dogs. And then you get this fantastic sort of hybrid, like the Jack Russell crossed with the Shih Tzu, the Jack Shit. But with these Cavaliers, it's not quite so simple. They have so many things going on. It may be all the same defect, that connective tissue during skull development that creates the syringomyelia and the foramen problems may all be tied into the connective tissue disorder that's causing this accelerated disease. And if we could work out what the defect is and breed it out, that would be absolutely fantastic. But in the meantime, we've got a lot of dogs that are affected like this. Let's move on, because we will run out of time, and I'm going to hand over to Paul now, who's going to consider slightly different angles here, and then we'll come back to me barking on about surgery. All right, Paul.
Thank you, Dan. So I got the diagnosis right. Yes, that was my biggest fear, getting up here and talking about something completely different to Dan, so that's good. As Dan mentioned there, I'm going to try and keep the energy up in the room, so feel free to interject at any point. If it does go too flat, I will be doing a song and dance, and I'd really rather not. It'd be quite worrying, and then I think if Dan joins in, it'll be even more worrying, so let's try and avoid that. So there are considerations to this case, and I think as a group of clinicians and animal health professions, we've done what we generally tend to do. So we've taken history, we've done a diagnosis, and we've jumped straight to what we think the treatment should be straight away. And we do that very quickly. We do that in a consult room naturally. But there are some considerations I think that we should just maybe just take a step back and think a little bit before we go down that treatment option straight away. There is a pet here in front of us. There's an animal with a condition. Obviously, we've heard about the state that the animal has been presented in, and we do things quite quickly as professionals in our minds. We make assessments on that animal's welfare, assessments on their quality of life, and whether or not they're suffering. And we do that quite instinctively a lot of the times. But is that always? Are we always in the same kind of alignment as the owner at this stage? I'm just going to put that question out, and then we'll come back to it in a minute. We've got prognosis, and we've heard a little bit this morning about evidence-based medicine and how we should consider that before we make any decisions. And we do have quite a lot of evidence around heart disease in dogs. And actually, some of the slides up there did suggest some quite bleak pictures of, actually, is this dog going to live beyond a year? Because if we're communicating that to the owners, is that going to start affecting the kind of decisions that they make there and then, and whether it might push them into, things like euthanasia a lot quicker? But the other consideration as well is the people involved. I didn't actually realise animals came attached to people until my first day in practice, because nobody mentioned that at vet school. It was all about the pets, and all of a sudden I'm facing an owner who was really upset about their pet, and I was like, oh, what do I do here? This is a bit of a dilemma. So, these people do walk into our consult rooms with, different emotions, different beliefs, different motivations for even having the pet in the first place. And I always try and go back to a rather awkward session in my final year where they brought actors in, and we all stood looking at each other a bit awkwardly while somebody was crying over a euthanasia of a stuffed teddy bear, and thinking, this is a bit weird, isn't it? What do I do about this? But then actually in practice, it actually happens, and it happens every day. And should this be affecting our decision-making around these cases? So I just have to apologise here. When me and Dan amalgamated our slides, we got a strange kind of hybrid of the RVC and PDSA. Some of these slides do look a little bit confusing, but this one's mine, Dan. So just to focus on welfare, I'm just going to throw it out to the audience. We've got lots of frameworks for quality of life and pain scoring, assessments and things like that. But we do have quite a robust framework for welfare. So we've got the 5 welfare needs as per the Animal Welfare Act in 2006. So just out there to you guys, what are the 5 welfare needs? I'll pick on people if you don't tell me. Just shout them out. Environment. Diet. Companionship. Behaviour, and the free from pain bit, and which comes under the health. Excellent. We're in a good place. So with this particular case, I just want you to think about it from the pet's point of view. How many of those welfare needs do you think are compromised as it presented? If you go back to the presentation of the animal, how many out of those 5? Just have a little think. This is clever. Okay, so a few of you thinking about it. Okay. About 132, is that right? Yeah. Less. Excellent. So majority of people, 2 or 3. So who answered 2? Can I get a microphone on them? Oh, let's have we got any mics anywhere? Yeah. Do you want to put your hands up, the 2 people? Can we get a microphone on somebody just to find out what those 2 welfare needs were?
Hello. The inability to express normal behaviour and pain and disease, I would say.
Okay, so the health one and the behaviour one. Any takers on that? Some of you added another one in there, a 3rd one. Who answered 3? Yeah. What was it?
Oh, sorry. Normal behaviour. I don't think this poor old dog, well, young dog, could run around, really.
Okay, so we had a behaviour up there with that one. Yeah, what was your other one? Health, behaviour. Should have written them down. That's what I have to do.
I'm very old. I've forgotten my name again.
That's an excellent get out. Brilliant. You've totally thrown me now. Okay, so again, has anybody got 4 in there? Because a few of you actually selected 4 or 5. Nobody's admitting to it. Okay. Yeah, can we just get a microphone there?
I think it was all 5, personally.
All 5?
Well, dog was overweight, dog couldn't move, dog couldn't behave right, dog had a bad prognosis, but, it's 5 to 6.
Excellent. Introduce a 6th one. So, again, even with quite a framework on welfare, we don't even agree in the room, necessarily all of us, about how many of those welfare needs. There definitely are compromising welfare situation, and we need to do something. So just move on to the prognosis. So we look at a little bit of evidence, and we've got some evidence from PDSA. We have about 350,000 animals registered with us, and we do see heart disease quite a lot. So of the cases that we see every year, there's about 2,500 diagnosed. That's across our whole hospital network. That's about 2.2% of our caseload. That's just putting in context of what proportion of our cases that is. And as we saw there, so 900, so about a 3rd of those cases will die within 12 months. And you can actually see the graph on the right-hand side. That's a graph of all the animals that are dying in that 12 months and just the proportion of at what point they die. And as you can see, there's quite a big a spike at the start of that, which is ultimately, I think, where the decision is made to euthanize. Oh, sorry. Sorry, this is heart disease. We got the wrong label on there. Sorry, this is what happens when we hybrided the slides together. So, of those that die in the first 2 months, that's about 65% of the total animals that die. So that all happens in the first 2 months. So that's not necessarily because we lose them. That's because those decisions are made quite early on about whether or not that client wants to continue or persevere with treatment. Yep.
Do we have an idea how many die at what point that haven't been euthanized? I mean, what would happen for the people who haven't decided to euthanize? I should know, but there's enough of them that just haven't got through on that.
So you mean of the remaining ones that, yeah. Yeah, so I don't have the exact information, but as Dan kind of suggested there, 18 months, I think, is one of the endpoints of a lot of these dogs. So just to put that in, and that is the right pyometra bar there, but just to put that in a bit of context of some of the other conditions, so of the animals that die within 12 months, when you look at that percentage mortality, you can see actually just presenting with a heart murmur doesn't really put you in good stead compared to the animals that present with hypothyroidism and the dogs that present with pyometra. So it's not great. The evidence behind this condition isn't great from our perspective, and I think out in the wider literature there. So the last thing is just around this approach is the kind of the people element of it, and this is something that we as an organisation are looking into quite a lot. What are the circumstances behind this particular client, Mrs. Eden, presenting to us? what are her beliefs around heart disease, and we've already had some in the room that are associated with our own personal experience through relatives, and even rewinding, what are the motivations for this owner to even have a pet in the first place? Because actually, if you get to the root cause of some of those, it can help you try and understand some of the decisions that are made. And I think, as any practicing vet will know, that this is sometimes a bit that we don't always get right the first time, because the clients that come into our rooms could be guided by a whole host of emotions that we don't fully understand within that 10 minutes, and that can often throw us about the decisions that we're helping them make. So just throwing it out there, and this is just a question that just to really sense check some of your guys' thoughts on this, but the question there, what drove this client to bring her dog to the vets? What emotion do you think she was feeling when she decided to phone up, make the appointment, and bring her dog in? Okay. That's about all of us there. Okay, that's interesting. So, who are the fear buttons? Well, let's just pick. Can we just pick one with the microphone? What is this client afraid of? What is she worried about? What she's scared of? Can we have somebody with a microphone going to? Yeah.
Well, she has a small girl, so she's fear that there's going to be an emotional impact on her daughter. She have to manage that and her own feelings, and she doesn't really know what the future holds, so that's pretty fearful.
Yep. Okay. So it's the change in the family dynamic, having to deal with her daughter and the potential grief involved, and the fear of things like that. Anybody else with fear? No. And how about the love people? Can we put hands up? People that selected love. Okay. Okay, I'll come back to that in a second. So just another question that I'm going to throw out there, and it's the same emotions, but I just want to ask, what took her so long? So just think, I'm going to reframe this scenario slightly. So this lady noticed that there was something wrong with her dog probably about 3 months ago, and she's been seeing the dog deteriorate and having struggled breathing and exercise intolerance, things like that. But can you just ask yourselves, why did she wait until this point, till she brought the dog into us? So it's a slightly different scenario. Okay, that's for you there. Okay, again, fear. Again, probably the same kind of reasons that you think drove her to bring it to the first place. So in both those scenarios, we've got a client that brings animal in promptly at first sign that they notice there's something wrong with their pet. You've got another client that puts it off as long as possible because there's something to be frightened of. In both those scenarios, you've chosen that actually that client's walking in to the consult room with a great sense of fear and dread. So that's not a great emotion to start off with, is it? It's not a great emotion to start making rational decisions on. And I think that's one of the things that we need to just be really aware of. If we are going to help this owner make a rational decision, we're going to have to cut through a lot of this emotion. We did quite a large amount of demographic survey work on our clients last year, and it looked at the kind of the groupings, the social demographic groupings of our clients, and actually it was just really interesting looking at just one aspect of that, and that was motivation to acquire a pet and how different that was across the different age demographics. Motivation to acquire a pet in some of the older demographics was very, very much around companionship. In some of the younger demographics, it's very much around being part of the family dynamics, and actually in some cases protection. So when you understand even the motivations for having pets, it helps you sometimes understand what some of the decisions that the client might be talking about or thinking about in their head to move on. So that was just me taking a step back and getting you all to think about some of the other things that might be going on before we delve into clinical treatment, because the clinical treatment bit hopefully is something that we should all be quite familiar with. So our clinical approach to this case at PDSA is probably no different to anybody else's. We need to stabilise the animals, we need to give them supplementary oxygen, IV frusemide, and diagnostics generally will be through thoracic radiographs. For those vets that are competent with scanners, they often put the scanner on there and can diagnose that there and then. We do have 51 hospitals, and at the moment we don't have a national protocol for heart disease. That is, we're planning to bring that in probably early next year. But at the moment, the majority of hospitals will go on pimabendin and frusemide as their first line. Anybody advocates of the 4-drug therapy for heart disease? Anybody using that with benazepril, spironolactone? No? Everybody doing this? Interesting. Okay. You put them on all 4? Okay. Anybody else? 3? Any advance on 3? Just interesting seeing what different approaches. So, I suppose that ongoing management of this case, and I put euthanasia there not because that's the thing that we push for as management of the case, it's just because those expectations, those early conversations need to be had, that euthanasia is an option, and at any point in the clinical deterioration of that animal, that potentially is where we go. But it's kind of managing the clients into the right place with that, and often their decisions to wanting to go to treatment, you have to explore, is this treatment at all costs? Is this, we have to keep this animal alive as long as possible because of that particular part in their life that they fill, or is it actually we're going to stand back and make rational and pragmatic decisions as therapy continues? But we do things like get the owners involved in monitoring this. I think resting respiratory rate is something universally used, where the clients can measure that respiratory rate at home when the animal's sleeping and give them a sense of are the lungs clear, are the lungs functional. And obviously things like salt-restricted diets and things are very practical. And there's a lot of interest and research around omega-3 fatty acids at the moment as well, which is, again, something that we'll take on board. So I guess our real aims of therapy in a pragmatic sense are, I suppose, mutual compliance. I have really come to hate the word owner compliance. It just sounds very much as like we're getting the owners to do what we want them to do, rather than us understanding what the owner's motivations are, what the owner's desires and needs, and trying to align them with our own. We need acceptable welfare. We need to judge that ourselves as professionals, but also let the owner make the decisions on what they would deem acceptable. Again, trying to align those two concepts. And we have to really protect this concept of the pet-owner bond. Pets do have a very kind of psychological and physical effect on owners, and we have to ensure that all the treatment decisions that we're making protects that bond and ensure that relationship with that person and their pet are in the right place.
Excuse me, could we just get a microphone on there?
Sure. That's all right. Yeah.
I basically just said about the grieving process. With any of these sorts of issues that you've just raised, and we've had the cancer one thrown in as well, the grieving process is something that a lot of owners have to come to terms with. And I think as vets, that is something that we have to also think about. And I think a lot of vets as well perhaps don't get the right training to deal with grief, and also in particular with having children involved, because obviously this will be, whether they've had it from a puppy. So I think that side of it must be in our aims of therapy.
No, absolutely. And if we go back to trying to understand the kind of the viewpoint of the people involved here, often people, as I said before, they come in with very different emotions and very different beliefs. And even your own staff in the hospital might have different emotions and beliefs around particular cases or conditions. And it's definitely a consideration you might need to make, but also that grieving process doesn't always start when the animal is being put to sleep. Often with these conditions, which have got a very clear endpoint, it often starts beforehand. But no, you're absolutely right. Okay. So at this point, I'm going to hand back over to Dan, who's going to talk a little bit more about the more advanced options for treatment.
Thanks, Paul. So we're here to try and talk about how far is too far, and of course that can be in the context of the animal, that can be in the context of the family environment that the animal is within. But obviously my role is to just concentrate a little bit more on the art of what is possible and really get your views on what you think about people like me that do what you might consider pushing the envelope, perhaps. And that's gone the wrong way. So we talked about how to treat this animal, and very important to point out that there's some really good quality evidence. If you look at the pyramid of evidence, there's some very good randomized controlled clinical trials comparing drug treatment protocols that are showing very clear benefits of certain drugs. And we're also getting very good evidence about the natural history of this disease, in particular in a population of dogs. And so we've got some pretty good evidence about, or good understanding about what happens to dogs with this disease. And so for some years now, actually about 20, I've been considering how best a surgeon might be able to help dogs with this acquired mitral valve disorder. And I've tried all sorts of things. There's a group in Japan who have reported a larger case series. Now, as evidence, quality of evidence goes, this ain't great. This is a cohort of 48 dogs undergoing mitral valve repair. And in order to do mitral valve repair, you have to put these animals under conditions of cardiopulmonary bypass. It's a big deal. Previously, workers in Colorado had tried to do this and not been very successful. I'd tried to do it and not been very successful. This group in Japan have been very successful by veterinary standards. And so 48 cases. I've worked with this surgeon, and I know he's done several hundred now, and his survival rates for these techniques approaching the sort of mid-90s. So you have 90%, 95% survival through the technique for mitral valve repair. And not only is a group able to produce spectacular results like this, in dogs where it's successful, although this is again a very small case series, but the results would seem to be durable. So we can take an animal that's got less than a year to live, and these animals can live 5, 6, 7 years. And the expectation would be, if we get better and better at this, that period of time will be stretched further and further. So, to David's point earlier, this ain't cheap. In order to attempt this kind of surgery, you either currently have to fly to Japan and visit a clinic just outside Tokyo, and the actual cost would be about £10,000 once you got there. We are currently early on in our experience, and we've worked directly with these clinicians, and we currently charge £8,000. Without going into too much detail, the operation involves replacing damaged parts of the valve and making the valve annulus, the part of the heart that the valve sits in, smaller again so that the valve leaflets are better coapted. And this is the team plus me from Japan. This is a couple of diagrams of the operation, and just sort of by way of explaining what needs to be done. So this is very challenging technically to achieve. And I think I have to say straight away that my personal success rate with this operation is nothing like as good as Dr. Uechi or Professor Uechi and his team from Tokyo. Probably a 50% survival is what I could boast right now. So, which statement best summarizes your thoughts on mitral valve surgery for dogs? I just don't think the profession should explore this as a therapy. It's just too much to put a dog through. I think it's a promising treatment, but I'm not comfortable recommending it to my clients, especially since there's only a 50% survival. I think it's a promising treatment that I'll make clients aware of, but it's ultimately their choice. And it's clearly the way forward.
Could I ask, in terms of failures, is it not waking up, or is it waking up in a very bad way? It makes quite a bit of difference.
It's a very good question, and it does make a big difference. It's usually not waking up. So if they wake up, then most of the time they're fixed. We do have occasionally patients that languish in our intensive care unit for a few days before they ultimately pass away. I have to say that's no different from traumatic patients or septic abdomen patients or pyothorax patients. Some of those languish in our ICU for days before we finally say that we can't do anything. So, or is it D? It's clearly the way forward. Even if survival rate is less than 30%, I would recommend it for clients if they could afford it. Okay, so we've got 130, oh, we've gone up to 138, that's great. Okay, so that's very interesting, and I'm very pleased to see that quite a few of you think it's a promising treatment. Nobody's at the point where they think it's clearly the way forward. There's quite a good number, 48%, who feel that either this is not something we should get into or it's promising, but we wouldn't recommend it. Now, would somebody be kind enough to actually explain why they think this is not something we should get into? Who voted for that? Can we have a microphone over here, please?
The reason why I said I wouldn't recommend it is because you said it wasn't available. You said they have to go to Japan.
No, I said I do it. I said I do it. Yeah, sorry, misunderstanding if I didn't make that clear. I thought. There's anyone else who said that they don't think the profession should get into this? Anyone who voted for that who would like to comment as to why they feel that way? It's fine if you don't want to comment, but it'd be interesting for us all to hear, I think. Yeah, up in the corner, thank you.
Thanks. Hazel Bentle, Hearts and Beds Veterinary Society. It's quite difficult to get these black and white answers, but I'm really keen that we should try to focus very much on the dog. This is a dog that's been sick for some time. I would assume, that I've never had valve surgery, that it is a painful procedure, however much it's moderated, and quite a high risk of complications. I'm also quite keen for the clients that we don't raise their hopes, because these people may already have come thinking that euthanasia is a real possibility, which is why they've delayed, and I think we can cause them additional distress as well. But it's never as clear as that, is it?
Well, I think they're all very interesting, very valid points. How do you think the first parents of the first child that underwent complete correction of tetralogy of Fallot felt? And it's a very similar thing, that first, there's always got to be the first, there's always got to be the first 10, there's always got to be the first 100. How do we find those first 100? Yes, please.
Yeah, I was going to say that when I first graduated, hip replacements weren't available for dogs. And when they first came out, people say, oh, I wouldn't put my dog through that. But now I refer several a year, and they're highly successful because techniques have improved. And I think there's a parallel there.
Thank you very much. And actually, it's a point that I have to make just coming up. Who thinks this is a promising treatment but wouldn't recommend it to their clients? Actually, you've got to go all the way back up there. Sorry.
Hi, Peter Jones, past president BVA. I stress I haven't been in practice for many, many years, but I feel that owners, and I include myself in this because we have a dog that is a very loved member of the family, are not always rational in the decision they make. And whilst they may feel that it's going to result in a good outcome, whether they can afford it or not isn't a rational decision that they often make. And I've seen this in other new areas of surgery that there's been a recent TV series on, and I sit there thinking, what would I say? And I think that people do need guidance because very often they will make decisions because of their overriding love for the animal, irrespective of when they can reasonably afford that treatment, which is why I opted for B and not C.
Thank you for those comments. I mean, it's really quite clearly, there's a comment down here, that there's no easy answer to this. It's very, very complicated because there are so many different emotions and factors at play. Yeah, John.
Yeah, I think it's right. Hazel said that, you know, it's not black and white, and a lot of the conversations that you have with clients aren't black and white. I noticed in your paper that you showed up from the Japanese study, although it was a small sample with 48, the success rate was very good, but the age range was 5 to 15, I think, in the sample set. So, I mean, that puts a completely different light on whether you're actually going to recommend something which is obviously innovative and cutting edge, or just make the client aware of it.
Let's just move on a couple of slides. I did look at the breakdown, but I think we'll move on. And actually, I had your point all set up to make. And so just humour me. Let's vote on this one and see how you all feel about hip replacement. You've all been pre-framed. You've all been pre-framed very nicely by a member of the audience. So the polling is open. Let's see how you feel about this. It might be interesting. It might be that a load of you don't think that hip replacement should be done either.
Dan, while people are voting, could I just ask you, going back to that last one, following on from a point that Emma made, if these dogs that you're going to do the mitral valve repair on, if they're entire, would you insist that they are neutered to stop them bleeding?
Yeah, that's a good question. I have to say most of them are already neutered. We generally wouldn't combine castration with valve replacement or valve repair, but we would certainly recommend that they're not used for breeding. Whether or not they are fit to undergo another anaesthetic after the repair will depend on how good the repair is. But you know, clearly there's a population of dogs. I mean, when they have a 3 or 4 out of 5 heart murmur at the age of 3, they shouldn't be used for breeding. So, you know, that's not just the ones that get to surgery that shouldn't be used for breeding, right? Vigorous breeding might just finish them off, yeah. Then they're out of the breeding pool. Sorry, there was a question in the front, or comment in the front, and there was one at the back.
Yeah, I was going to bring it up again, actually, just to be a bit clearer about it. I think the danger is, I saw quite a few clients in practice who habitually get the same breed of dog, and you do a vaccination check at 4 and say, did you know she had a heart murmur? And they say, oh no, I didn't, but my last 4 died of heart disease. And as soon as you start to be able to fix everything, there's no incentive for them to stop buying diseased animals. I was at the AHT last week, and you walk around the ophthalmology wards all full of pugs and brachycephalics with their eyes falling out. You go into the orthopaedic centre, it's all full of labs and mastiffs and everything. And I just feel like the more we fix, the less we are going to drive that change for healthier animals.
Yeah, I agree. We even run a brachycephalic clinic at the Royal Veterinary College, the noisiest clinic day we ever have. Sorry, there was a comment at the back.
Yeah, Dan, I was just going to ask you, actually, before the others, how would you respond when you've agreed to do the surgery and the owner says, good, because I really want to breed from her?
Well, that would cancel them out of the equation. That would be a very difficult conversation, but one that I wouldn't have any qualms about having. Yeah. So we've got a split there, interesting split. It's a promising treatment that I'll make clients aware of, but it's ultimately their choice. And I think actually these two choices aren't mutually exclusive, really, are they? It's tried and tested therapy that's gained universal acceptance. I mean, it's their choice because it costs, but it's not their choice because we don't think it's a very good treatment. Is that a fair comment? I mean, if we go back to the group of, if I make a comment, then I'll come back to both of you, about it's a promising treatment, but I wouldn't send my patients there right now. That's quite a tough thing to say, isn't it? You're quite happy for other people to go through that process, but your patients are somehow protected by you from that. They might not want that protection from you. They might want to hear about this. In fact, most of the people that come on knocking on my door saying I want valve surgery don't hear about it from their practices. They search it on the intranet. That's how they find out that we're doing it. And actually, ironically, the last patient I operated on emailed Masami Uechi in Japan and Chris Orton in Colorado, both of whom said you should go and see Dan Brockman. She lived in St. Albans. Sorry, who was first? Yeah, if we could have this comment here first, and then I think it's Maddie over there.
Hello, Adele Williams, horse vet from the University of Surrey. I just wondered, with respect to insurance companies, if they pay towards this procedure or not, and if so, how much do they pay?
It's an acquired disease, and unless it's not a write-out because the animal had a heart murmur when it's insured, they will pay whatever they have in their provision towards this. Yeah.
I mean, I'm just thinking about horse policies. Normally, the maximum is about £4,000. Is that the same with small animal policies?
No, you can get 7,500. There used to be an unlimited one. I think they've stopped producing that product. We've abused that one.
Hello, I'm Madeline Campbell, veterinary ethicist. I just wanted to pick up on the point you said about it's their choice because it costs, but it's not their choice if we think it's the wrong thing to do, because I think you've touched upon one of the key differences between veterinary ethics and medical ethics, which is animals, from a legal point of view, are owned property. So unless they're contravening the Animal Welfare Act, the owner is entitled to say what they want done to their animal, and that can bring them into conflict sometimes with the vet. So they might, for example, want to euthanize, and the vet doesn't think that's in the animal's best interest. Or conversely, they might want an operation like this done when the vet doesn't think that's in the animal's best interest. And the big difference between veterinary medicine and human medicine is that in those situations where there's an argument about best interests, whereas in a human case, the doctors can go to court to get a judgment made about what is the best interest of the patient, at the moment, there's no equivalence in veterinary medicine. And I think that's a key kind of conflict in veterinary ethics at the moment.
Very interesting point. Peter had a comment.
Peter Ginman. The point I was going to make was one of who does the surgery. One of the issues with the human is that you can go and look up which surgeon, which time of year, doing the surgery, in which hospital, has a success rate that is worth even thinking about. When we were looking at kidney transplants 15 years ago plus, one of the things we said at the time was it had to be suitably qualified persons. In both of these, who's going to do it, and should we actually be limiting who does it?
I think that it's a very good point. And to this day, there is no formal training process for veterinary surgeons training to do renal transplantation, although it's done in several centres in the US still. There's certainly no training program for people who want to do open heart surgery. And so just as there was no specific training program for the first series of hip replacements, those who learnt on the first cohort of patients have trained others in their wake. So that's a really, what constitutes appropriate training, an appropriate level of training, because nobody goes to learn how to do this. Very different, again, from human medicine, where cardiothoracic training programs exist and are monitored, and outcome parameters are documented for everyone to read. So we're actually probably just about up time-wise, and I just wanted to leave a couple of additional thoughts in your head. So what is the basis for the acceptance of these therapies? And I like to sort of break things down very similar to the way that Paul was trying to break it down. First of all, I believe, obviously, you can't ignore the patient and just kowtow to the client's wishes, but you can't ignore the clients and just do what you think is right for the patient all the time, because you'll get into conflict of the type that where the client doesn't want to do what you think you should do for the animal. So, has the animal got a good life? Is it a life worth living, or is it a life not worth living? And that might be what would cause you to intervene in the first place. What do we stand to gain? How would we define success? So success for a 5-year-old dog with mitral valve disease having surgery would be for it to live a much improved quality of life. I'm not sure that the length of the better quality of life is all that important to the animal. It might be to the clients. But if you can get that animal to live a much better quality of life, i.e. less medication, better ability to exercise, good appetite, pain-free, and so on. So in this context, this dog is a 2-year-old dog, and so the potential to do good for this dog is quite huge. The cavalier lifespan, if we could reverse what's going on in the heart, or at least arrest it, reverse it a bit and arrest it for a long time, we stand to gain a lot in terms of additional lifespan as a good quality. But bearing in mind everything that Robin said earlier about explaining to the clients what the parameters, where the line in the sand might be for when this dog's life has tipped from being a life worth living to being a life not worth living, we need to make that decision together and prevent suffering. The risk or the cost effectiveness or the risk benefit profile of these procedures is what troubles most people, and it troubles me. And as yet, there isn't a lot of robust evidence to support the probability that this is going to be a long-term winner in terms of treatment. And we all worry about what compromise in welfare is acceptable in the short term in an attempt to improve health and welfare in the long term. And does the animal know or care about the long term? And who makes the judgment and how are those judgments reached? And finally, who should be the strongest advocate for the animal and its welfare, and how do we make decisions? Do we anthropomorphize? Not very scientific, but very visceral, and something that clients can understand? Or do we turn to the literature and create this knowledge gap between what we understand and what the clients understand, which will make them decision averse? We have to find something in the middle. So to whom does the veterinarian have the greatest responsibility? Is it to the animal or the owner? Big question. How do we actually determine the quality of life? We're working very hard on quality of life assessment tools that are a little bit over and above just is it eating, drinking, and it doesn't run around and wag its tail. And you might rightly ask the question, what would motivate someone like me to push the envelope when it comes to animal treatment? But if no one ever pushes the envelope, we would never make any progress. And so we've got to find a way to make progress, I believe. Otherwise, if we're not going forward, we'll be going backwards. There's no standing still. So is pushing the envelope ever the right course? I believe it is, but there may be those of you in the audience who feel strongly the other way. And for any individual animal, we don't know what the outcome of a treatment is going to be. We can look at populations of animal and say the probability is this. Owners find it very difficult really to deal with probabilities sometimes, and then that can widen the perceived knowledge gap. But what probability of success is acceptable? And as an academic clinician involved in clinical research, it's my job, partly my job, to work out how we generate this information so that we can make well-informed decisions. But we've got some fantastic developments, got groups like the PDSA that do a fantastic job of auditing what goes on in our practices. We've got Vet Compass and similar databases being developed that will help us answer some of these questions. So I sense that probably we could go on debating this for some time, but I think we probably ought to draw it to a close there. Very vigorous nod in the corner of the room there. So thank you all for your attention on behalf of Paul and myself.